I'm Jared Bunch. I'm happy to discuss the talk on the impact of atrial fibrillation in the heart failure ICD patients, specifically the lessons learned from the INTRINSIC RV study. And this is on behalf of the INTRINSIC RV investigators that include Dr. John Day, Brian Olshansky, Kira Stolen, and Chris Mullen. As regarding disclosures, I do receive speakers honorarium and faculty honorarium from Boston Scientific, Sanofi Aventis, and also Biosense Webster. Atrial fibrillation is the most common arrhythmia that we see in clinical practice. It increases with the acquisition of coexistent cardiovascular disease such as heart failure and hypertension, but also has been increasing in the population in general, and we account for these risk factors. We know in patients, we know that atrial fibrillation independently increases mortality in patients with and without cardiovascular disease. And recent studies have suggested that atrial fibrillation increases mortality in those with severe left ventricular dysfunction despite optimization of medical therapy. When we look at atrial fibrillation in general, and this slide highlights a part of our data research at Intermountain Healthcare, when we looked at patients that had a CHAD score of 1 to 5, and we looked specifically to understand if the CHAD score itself conveyed the risk alone, or if atrial fibrillation, in addition to the CHAD score, added risk. And what we found was across all 5 CHAD scores that there was an increased risk of stroke in patients that have atrial fibrillation, and as we gain more CHAD scores, that becomes substantially higher. But patients in general were found to have much higher risk if they had atrial fibrillation. When we look at MACE, or the composite of death, heart attack, and stroke, we find a linear increase across the CHAD score of risk, and that atrial fibrillation independently increases the risk in those that have the arrhythmia compared to those that don't, that have similar underlying CHAD's risk. Really the mechanisms of atrial fibrillation and heart failure are multitude, and some of the things that we have seen is they change the cellular ion channel activities. We see changes in channel expression, atrial stretch, atrial fibrosis. This results in heterogeneity of conduction and an increase in sympathetic activation. And all these mechanisms ultimately lead into atrial arrhythmias and the coexistence of the state of atrial fibrillation and heart failure. So some background on the INTRINSIC RV study. This is the inhibition of unnecessary RV pacing with AV surge hysteresis. It was a multi-center randomized trial in patients that received an ICD. And they are randomized either to dual chamber rate responsiveness or an atrial ventricular surge hysteresis program from 30 to 130. Or a single chamber pacemaker program, essentially to minimize any pacing at all at 40 beats per minute. The primary endpoint was composite of all-cause mortality and heart failure hospitalization, and ultimately the outcomes suggested similar outcomes between the two pacing schemes. We became interested in this because this is the new generation of devices that have improved diagnostics. This device in particular had an atrial rhythm classification algorithm that could let us understand the incidence and the duration and burden of atrial fibrillation. And it was a three-dimensional approach looking at atrial arrhythmia classification, maximum rate, range, and interval variation. So we looked at patients that had a history of atrial fibrillation, and we looked at those that developed atrial fibrillation the first 3 months after implant. This slide shows the demographics of those that had atrial fibrillation or history of atrial fibrillation at the time of implant and those that did not. They were randomized to similar pacing schemes. The patients that had atrial fibrillation were older. They tended to have a little bit higher rates of more advanced heart failure. And they had more often a history of congestive heart failure. And as expected, they were more often on antiarrhythmics and medications for their heart failure. But other markers appeared to be similar. We looked at this group with a history of atrial fibrillation versus those that weren't in 3 models to understand the hazard ratio of death, heart failure, a composite, or ICD shocks. When we look at the unadjusted model, there was a high hazard ratio in all outcomes of nearly 2 or greater than 2. The first model then that was adjusted was looking specifically at demographics. Can we account for this with baseline demographics? And as you can see on this slide, that despite accounting for the demographics, there was still a significant increase in death, heart failure, and composite and ICD shocks in those that had atrial fibrillation. And finally, we created a second model in which we added medications, both for heart failure and arrhythmia. And again, we found an increased hazard of all outcomes in patients that had atrial fibrillation. So these really show nicely that atrial fibrillation increases risk, or a history of atrial fibrillation at the time of ICD implantation is a marker of high risk. These are the Kaplan-Meier graphs looking out to 8 months and by atrial fibrillation history. And what you can see is an early separation by a history of arrhythmia in risk of death, heart failure hospitalization, first ICD shock, and the composite of the 2. And probably in looking as a care provider, the most concerning part is that the lines continue to diverge based on this history alone over the complete study period. Our next question was, what about the patients that develop atrial fibrillation, either that had a history of atrial fibrillation and developed it during the first 3 months, or had no history of atrial fibrillation and developed atrial fibrillation? And on the left here are those that had no history of atrial fibrillation, and on the right, those with atrial fibrillation. We'll focus first on those with no history of atrial fibrillation. As you can see, the pacing algorithms were similar, the age was similar, heart failure classification was similar. There was a slightly lower incidence of dilated cardiomyopathy, but everything else was very similar between the 2 groups. When we focus on those with a history of atrial fibrillation, those that had a frequent atrial fibrillation during this 3-month period were less often male, had more advanced or higher levels of heart failure, were more often to have ventricular fibrillation, suggesting this may be a significant marker of worsening cardiomyopathy, and were less often found to be on an ARB medication, but similar rates of ACE inhibition. This slide shows the outcomes by history and short-term incidence of atrial fibrillation. And on the bottom, on the left, we see those with no history of atrial fibrillation, and on the right, those with a history of atrial fibrillation. And as you can see, all outcomes were worsened with atrial fibrillation developing in those that had no history. And you could see that those that had a higher that had atrial fibrillation and it became worse during the study period had worse outcomes compared to those that didn't. Probably the most enlightening is looking at those that develop atrial fibrillation and those that have atrial fibrillation during the study. And really, these patients ultimately behave more like those that had long-term atrial fibrillation. What we see here is, again, the 3 models, but specifically looking at those that develop atrial fibrillation after device implantation. We see an increased risk of all outcomes. It's only statistically significant for death, but there's a trend across all of an increased hazard of death, heart failure, and ICD shocks. This persists for death both when we adjust for baseline covariates as well as for medications. And again, a similar trend seen after adjustment for all other outcomes. This is survival based upon incident and history of atrial fibrillation. And the highest risk over the event time were in those with no history of atrial fibrillation that developed atrial fibrillation. And this paralleled those that had a history of AFib and was slightly worse. And the lowest risk group were those that had no history of atrial fibrillation and had no atrial fibrillation after implant. So certainly history of atrial fibrillation is a strong marker of mortality, but even more so after you implant a device, early atrial fibrillation also is a high marker of mortality. And as expected, looking at ICD shocks, those that had new atrial fibrillation had much higher risk of ICD shocks. There wasn't enough events to really stratify appropriate versus inappropriate, but both were driven by the atrial fibrillation. And those that had no AF and no history of atrial fibrillation had the lowest rates by far. So what does atrial fibrillation do in patients with heart failure? Well, we have atrial fibrillation, and it causes rapid ventricular rates. And this can lead to ventricular dilatation, ventricular wall thinning, ventricular contractility, and an increase of sympathetic activation. If we slow these heart rates down, we can improve the ventricular hypertrophy that was thinned, and we can decrease ventricular relaxation and see some positive remodeling of the heart. So this really raises the question, if we can, is the outcomes that we've seen in this study related to the rate alone or the arrhythmia? So we tried to understand that, and this is a graph that shows the population stratified by a well-controlled heart rate less than 76 and a fast heart rate of greater than 76, and looked at mortality and heart failure hospitalization. And those with no atrial fibrillation, there is compared to those with atrial fibrillation. And you can see there's a substantial increased risk with a higher heart rates for both those with and without atrial fibrillation. But the relative risk is most substantial when we compare the low heart rate with those with atrial fibrillation and those, again, with a faster heart rate without atrial fibrillation. And as enlightening is the fact that the highest relative risk between the two groups is found in those with a slow heart rate. And when we look across this, if we look across the complete heart rate strata, what we could see is this is persistent across almost all heart rates, that atrial fibrillation increases risk of mortality and heart failure. And so in most of the risk, or the highest relative changes in the lower heart rates. This suggests that the arrhythmia itself outside of the heart rate is pathologic in the association of mortality and heart failure. This ultimately leads to the question of, can this be applied to the real world? Or is this reflection of a study with an aggressive atrial algorithm that helps us understand this arrhythmia? This is a nice study from the Netherlands in which they specifically looked at the same question, but in a general real-world setting. And they concluded in the population currently receiving ICD treatment outcome outside the setting of clinical trials, that atrial fibrillation was associated with mortality and appropriate as well as inappropriate device discharges. And here's their graph of their findings. And what you could see after an ICD is implanted, and they went a step further than we did in classifying subtype of atrial fibrillation. Those that have chronic atrial fibrillation had much higher rates of mortality over 3 years. The mortality, despite having an ICD, near 40%. Those that had less aggressive forms of atrial fibrillation, the mortality still was high at 20%, compared to those that had no atrial fibrillation when it was near 10%. So in summary, in this intrinsic RV study population, a history of atrial fibrillation at the time of ICD implant or new onset atrial fibrillation identify additional risk of heart failure and death, despite optimization of medical therapy. In all patients, high heart rates in comparison to low heart rates in ICD patients increased risk. Atrial fibrillation independent of heart rate increases risk of mortality and heart failure hospitalization, suggesting that the arrhythmia itself, as much as the rate, has impact and in the cycle and the poor cascade of atrial fibrillation and heart failure. And that the increased relative risk of atrial fibrillation was the most pronounced in the slow heart rate. In conclusion, these data from a contemporary ICD cohort provide insight into the dynamic interplay of atrial fibrillation and heart failure. AF remains a powerful risk factor of adverse outcomes despite current pharmacologic therapies. Although an elevated heart rate increases risk in ICD patient, AF adds additional risk. The intriguing association of low heart rates and the highest relative risk with AF requires further study, but may provide insights into mechanisms of risk and ultimately therapies for intervention.